Title. Dr. Afshar from UCSF. Thank you.
Thanks very much, and thank you also for the assistance with the PowerPoint here. So I'd like to first thank the meeting organizers for having us here. It's always a wonderful event that you guys put on here, and really greatly appreciate the opportunity to speak to you today. So actually, I was just speaking to a group of ophthalmologists yesterday at a meeting and was talking to them about the evolving care pathway for uveal melanoma and for uveal pigmented lesions in general. And there's some overlap that with what I'll be talking about with you guys today. First off, I did also want to mention that the last time I was speaking to this group here, this was a couple of years ago, we had presented findings from the OMF survey study, which was really the first of its kind to really delve into the patient experiences and that of their caregivers and support. And along with Dr. D'Amato and Grant Allen and colleagues, we did actually publish this in the journal Ocular Oncology and Pathology. This came out last year. And what was great about this study and what we were very pleased about was actually in the appendix of that study, we were able to include all of the patient comments as well. And so really it's great that your voices are now heard and in print as well. And these are just some of the comments from the surveys that actually made it into the article itself. So talking about choroidal melanoma, uveal melanoma, one thing we as ophthalmologists can tell our patients when we counsel them initially is we have a pretty good sense for how effective our treatments are. As Dr. Sato had mentioned, with proton beam radiation for choroidal melanoma, success rates are higher than 95%. This is a patient who was treated, was doing well 10 years later. Plaque radiation, also very effective, upwards of 95% chance of killing the tumor inside the eye. So we know the treatment works in terms of eradicating the tumor in the eye. However, when we're sitting on the other side of the chair with you guys, when patients come in with a new diagnosis of choroidal melanoma, we're often working with incomplete information. So I think the most important information that patients often want to know is, will this treatment actually prolong my life? Is it going to affect survival? So that's really the larger question that's hard for us to always answer at the time of the first visit. Now there's a number of predictive features that have been looked at for knowing who's at risk for spread down the line. Some of them include the size of the tumor, the thickness, different histology parameters, so that's the actual look at the cells under the microscope. A lot of that's being replaced by genetic information of these tumors, and that's really supplanting some of these traditional features that we used to look at. The trouble is, unfortunately, we can't just look in the eye and tell somebody based on the appearance of the tumor what their risk is of spread. And so these are images of a couple of patients here. This lady is 52, had a thin tumor, 2 millimeters, was actually watched as a nevus for several years, had some growth and change, was successfully treated with proton beam radiation. Unfortunately, though, 3 years later, had spread. This is another patient who, same age, came in with a much larger, much thicker tumor that you can see there. And this patient was alive and well 5 years later. So what a lot of this boils down to is the genetic profile of the tumor itself. There's a number of genetic changes in these tumors that we know are very important in determining who will eventually have risk of spread. Some of these include loss of chromosome 3, as Dr. Sato had mentioned, and also the gentleman from Aura. A mutation in the BAP1 tumor suppressor gene on chromosome 3, and of course, class 2 gene expression profile on Castle testing. Now, sure, yeah, please, that'll help. Now, one of the things that's changing quite a bit in the field is, initially, as ophthalmologists, if we look at a potential tumor in the eye and are looking at the appearance, there are a number of features that can tell us, is this truly a melanoma? Is it really just a nevus? Is it somewhere in between? And this is actually an acronym by the Shields group. This is from about 10 years ago. And things like thickness over 2 millimeters, whether or not the patient had symptoms like flashes, orange pigment on the tumor, these are all things, these are all clues that this may actually be a melanoma. Now what we're finding is, what's changing is with recent new instruments in vitrectomy equipment, so for surgical retina instruments, we now have these very tiny, very small cutters that are 27 gauge. They're even smaller than an IV you put in a hand vein. And through this, we're actually able to perform biopsies. So just to summarize, what I was saying is the instruments in our surgical retina field have advanced so much that we're able to actually sample very, very small tumors that we weren't able to sample before. So in the past, whereas we were kind of observing things that were very small, looking for growth or looking for change, our goal as ocular oncologists is we want to catch these things before they grow, before they spread. And so now we're actually able to do that with these biopsies. So this is actually a video of a biopsy of a tumor. And I'm just going to press play here. And for this, you may actually want to dim the lights just momentarily and then bring them back up because it'd be a little bit hard to see. So this is actually that small, fine needle instrument. We do apply freezing treatment as the ports come out. This is, again, that small 27 gauge needle going in to the tumor again. And this is how we withdraw cells for a biopsy. So this is how we are able to provide confirmation that the tumor is what we think it is and also that the genetic testing results are accurate. And what we're also finding is the ability to biopsy these very small tumors is actually, in some cases, changing the way these are managed as well. So this is a 40-year-old gentleman who came to see us, was actually from Australia, was coming back and forth to San Francisco because of his job. And this was a choroidal melanoma of his left eye, very small, quite early. This was only 0.6 millimeters thick. Now, there are other things that we look for to prove that it's melanoma. So on those images up top, if we see that white fluid that's tracking down from the spot, that can be very suggestive. And there's also fluid underneath the retina, which we can see there and there. Those are also clues as well. So this patient, young guy, had perfect vision and was very, very adamant that he didn't want to have radiation unless this absolutely was certain to be a melanoma. And so we performed a biopsy. So in this case with the biopsy, on the areas that are circled in red, this is actually where the needle goes through the retina. The complication rates from this are actually very low. You get a little bit of transient bleeding that tends to go away on its own. With this biopsy of this tiny tumor, the patient was able to have a Castle result of class 1A, and we did send cells to the pathologist, confirmed it was indeed melanoma. So this patient was urgently treated, and now 3 years out is doing very well with excellent vision. This is a 39-year-old lady who came to us, actually. She was seen in Mexico for many years, and her retinal specialist in the Bay Area kind of panicked and says, "Oh, is this really melanoma?" So her tumor is here above the center of the vision. There's also fluid, which is suspicious for melanoma. But she said, I think this has been watched for years in Mexico. I'm not even sure if it's changed. So in her case, she was pretty hesitant to actually undergo radiation because she wasn't even convinced this was something new. We performed a biopsy for her as well. Interestingly, the pathology came back as a melanocytoma, which is actually a benign, non-cancerous growth. Genetic testing was also reassuring, and this patient's been monitored for a year and has been doing great so far. This is another patient here, an 83-year-old lady. She had an atypical looking nevus, freckle of the choroid that was watched for several years. She came back and it had shown growth actually, and it was larger in the photograph and a little bit in the ultrasound as well. This patient, given her age, was also somewhat hesitant, had other health problems, that, I don't really want to treat this unless this is for sure melanoma. And also, if it's already acquired dangerous mutations, I'm not sure I want to treat this. She had a biopsy as well. Pathology confirmed what it was, which was melanoma. And her genetics were favorable. So she was treated with a plaque, and 6 months out is doing well. This final case I want to show you here is a gentleman who came to us. This gentleman was an Asian patient. The majority of our patients with this problem tend to be Caucasian, but there are Hispanic patients, Asian patients, and I've even had a couple of African American patients with melanoma. Nevertheless, a somewhat unusual presentation of this. This was a choroidal melanoma of the left eye. His vision was nearly perfect in that eye, and his other eye wasn't doing so well, had macular degeneration, some bleeding, and so this was his good seeing eye. Now, he was extremely hesitant to undergo radiation or eye removal, and so he wanted a biopsy as well. So the biopsy actually confirmed that he had melanoma. Class 1 Castle results. And this patient actually pushed us for endoresection. So that's a surgical resection of the tumor without radiotherapy to try to preserve vision. So for that procedure, which I performed for him a couple of years ago here, we basically use retinal instruments to eat away the entire tumor, and we also take the retina that's overlying the tumor. We apply laser to the area that's been resected, and we put a big silicone oil bubble in the eye that stays for several months, which we eventually removed. This patient now is 3 years out with excellent vision and no evidence of metastatic disease. So just to summarize, biopsy of small tumors can be very informative. We're also quite fortunate that we have vastly improved surgical techniques to be able to sample tiny tumors that were years ago not able to be sampled. Genetic testing does offer a wealth of information, so it can help us confirm that what we're seeing really is a choroidal melanoma, and also can be very helpful in telling us what the odds are of it to ever spread. In some cases, select cases I would say, and this tends to be cases that are small or borderline, genetic information and biopsy can be quite helpful in deciding what to do. So is it safe to monitor? Should these patients be treated with radiation? And so that seems to be the direction that things are shifting in. Just wanted to thank some of my colleagues here and our grant support, and open the floor up to any questions.
Had one. A lot of people on the website had their eye removed or had radiation and stuff prior to there being a test or genetic testing. Can they go back and do a genetic testing now, just off of the saliva or the blood sample?
It's an excellent question. So I think the testing that's going to be of most utility, the most value for them, is actually going to be genetic testing of the tumor tissue itself. Now, if an eye has been removed, typically the eye is saved by the pathologist at whatever hospital you're at. And if it's done in a manner where there's still slides that are paraffin-embedded slides of the tumor tissue, that actually can be tested for genetics. Now, if the tumor's been radiated years ago, that becomes a little bit more challenging. So what happens is the tumor cells die within the eye, and then it's not reliable to do some of the genetic testing. But it's an excellent question, and one of the studies that we're actually working on at UCSF is we're looking at doing genetic testing on historical samples of patients who were treated decades ago, actually. So it is possible to do that. Excellent question. Mr. Adele.
Are you at UCSF still doing post-treatment biopsy?
So indeed we are. Now it's important to keep this in mind. So what Mr. Adele is referring to is the majority of testing methods for uveal melanoma are validated for before radiation. Now the reason for that is there's concern that the radiation itself might damage the genetic machinery in the tumor, and that the genetic testing wouldn't be accurate. Now with certain DNA-based forms of testing, such as the next generation sequencing test that we use at UCSF, it actually is validated for use after radiotherapy. But the Castle test, for example, I think anything with RNA expression, it needs to be done before radiotherapy. So.
And is that 90 days? What's your window?
If you're going to have a biopsy after radiotherapy, probably advisable to have it as soon as you can. I know that my colleague, Dr. D'Amato, was doing it in England on samples that were done with MLPA analysis, which is a little bit different, but they would do them within a week or so. We tend to do them as soon as we can for a convenience standpoint too for the patient often.
I got a quick question. Is there any reason why you would not biopsy somebody that came in with what you?
It's an excellent question. So,
and I'm sorry, it might be 2 or 3 questions. That question first. Well, go ahead. I'm sorry.
well, really we leave it up to the patient. So I would say probably about 90% of patients who we see do actually request a biopsy. But it's all, it's a personal choice. It's information that the patient is able to have, but it's not information that everybody wants. The vast majority do request it, but we let the patient guide the decision making with regards to whether or not they want a biopsy or not. For the majority, I would say the vast majority of choroidal melanomas or uveal melanomas, the diagnosis is clinical. So usually it's obvious to us. So by looking at the tumor, by looking at the features, we can say, okay, this is melanoma because it's over a certain number of millimeters thick, the shape looks classic, it's got orange pigment. So usually we know what we're doing in terms of knowing that it's for sure melanoma. Now, the cases I was presenting here, these were some lesions that were small. So perhaps there were nevuses that were benign but were transforming into a melanoma, or in the example of the melanocytoma, that's actually a benign lesion. So in those situations, a biopsy can be helpful not just for prognostic purposes, but also just to confirm that it is what we think it is. But for the majority of cases, it's usually actually pretty clear that it is indeed a melanoma. So in those situations, the biopsy is more for obtaining genetic information to tell the patient what their risks are for ever having spread.
Will the biopsy itself increase the risk of spreading because now it has the ability to get out of the eye?
That is an excellent question. So not as far as we know. Now, there's two parts to that question. The first is, I think what you're asking is there a possibility of the tumor cells coming outside of the eye through the biopsy procedure itself? Is that what you're asking? Okay. So that's an excellent question. Now, there's only been, I think, a very small handful of cases where a biopsy led to afterwards tumor cells being seated in the wall of the eye, presumably from where the needle went in and out. Now, there are a couple of different ways to do a biopsy. Now, if you're doing a plaque, some people will just do the biopsy right through from the outside of the eye and put the plaque on afterwards. The most recent case that I saw was a case report that was published from Will's Eye. It was a few years ago. That's how that biopsy was done. Now, there is some evidence to indicate that when you do the biopsy from the inside of the eye, which is the way that I showed where you're putting needles from outside the sclera, but you're going through the vitreous, through the jelly in the middle of the eye, the risks of seeding the eye wall tend to be theoretically lower. And also, I know I do, and I'm sure others do as well, we actually put freezing treatment applied to where we take the needles out. So I've never had a case of that. I'm not aware of any cases of seeding of the eye wall at UCSF. And again, even in all the scientific literature, out of the thousands of biopsies that have been done everywhere, there's only, I think, a couple of cases that have been presented. So that theoretical risk is quite low. That being said, that could be another reason if a person is very concerned to have the biopsy after radiation, which is a possibility in some cases with some forms of testing. So what I would generally let you know is the biopsy procedure tends to be quite safe. The risk of complications is quite low for the majority of complications, and the risk of spreading tumor or seeding is theoretically extremely low also.
Is it accurate that if you did not get the biopsy and it's past the amount of time to go back and do it, that you're precluded from most clinical or all clinical trials?
It's a good question. I think some of that would depend on what stage the trial is in. So with some of these more investigational therapies, the enrollment may be limited to patients who have a known, proven high-risk tumor. So if that's the case and you're excluded, that's possible. Now, another thing, though, too, is every year that goes by that somebody is disease-free, your risk drops off. And as Dr. Sato had mentioned, the risk after 5 years goes down, and then after 10 years goes down even more. So having made it out to a certain level of time after being treated is also a really great accomplishment in and of itself. So, Ms. Ashburn.
So my understanding was, as an outside possibility, is that if a tumor sets up somewhere else in the body, so time has passed from the original eye issue and it's set up somewhere else, that testing can be done on that particular tumor that would then answer what she's saying, is that you would then have information about the genetics of the tumor.
So it's a good question. So if there is disease that spreads outside of the eye to the liver, for example, at our institution what will happen is they'll actually have a biopsy sometimes to prove that it really is a metastasis from the eye. And genetic testing, at least the testing we have at our institution, can actually be done on the metastasis too, yes.
So then, just to follow up what she was saying, then that would then allow entry into a clinical trial, if that was the trial you were choosing.
It could. Now, some trials might be set up for patients who already have metastatic disease, so if that's the case, I think that patient would qualify.
Do you see any way in the future, for example, I was treated with proton beam therapy in 2017, and for an indeterminate tumor that had many suspicious features of melanoma, but just not the height. so my doctor recommended not doing a biopsy, and I didn't understand the value or the prognostics related to it. I just thought it would say it was melanoma or not melanoma, and we were going to treat it anyway. So I'm just wondering, like, is there any way for me ever to get any information on it?
It's an excellent question. Some of it depends on the size of the tumor. Now, I will let you know, I mean, it is challenging from the surgical standpoint when it's under 2 millimeters. That being said, we do have experience now and have done it successfully. It sounds like you received excellent treatment and it was very conservative, and that's really the way to do it. And also, the situation that you're describing is also really the paradigm that it's the direction things are shifting in, which is to treat these things as early as possible. So, that being said, depending on the thickness of your lesion at this time, it is actually possible that there may be room for a biopsy even now. It depends how long the radiation was, how thick the tumor is, but there actually probably still is a possibility. Great questions. Anything else?
From a pathology standpoint, is mitotic rate taken into account, and is that predictive of future spread?
It's an excellent question. So mitotic rate basically refers to kind of the activity of the cells that are in the tumor. To get mitotic rate, you have to have enough tumor cells. So it's easier with a larger tumor, larger sample. So in these situations, these cases that I showed, the amount of tumor tissue is very little in a tumor that's like 0.6, 0.7 millimeters thick. So there may not be enough to actually accurately get mitotic count. And we always prioritize genetic testing if we have a very limited sample over just routine studies like histology or mitotic cell count. The reason for that is from what we've seen in the research that we've accumulated over the last, this really goes back to the late 1990s in this field, genetic information seems to actually be, much more valuable than just the mitotic rate. But it's an excellent question. So the higher the mitotic rate is, that can also increase the risk as well. Yes?
Hi. For those of us who have been diagnosed with ocular melanoma, is there a general gene testing that can be done for our children?
So it's an excellent question, and one that we receive not infrequently. So the vast majority of uveal melanomas are not inherited. So it means it's a sporadic mutational event within the eye of the individual patient. Now, less commonly, there can be a familial inherited cancer syndrome, or it's called a BAP1 cancer syndrome, where essentially the patient will have a predisposition to have multiple tumors in various organs, including the eye, and it's due to a mutation in the BAP1 gene. So testing for that kind of cancer syndrome can be done for family members. Typically, though, the concern for a BAP1 cancer syndrome is not quite as high unless the patient has a reason for us to suspect that, so multiple other tumors, things like that. So in general, the vast majority of these uveal melanomas tends to be sporadic, and hopefully your family member's risk would be like the general population, which is about 5 to 6 per million of the population per year.
So there is a blood test for this BAP1 mutation?
Correct, yes.
Okay.
Yeah.
Thank you.
What about in a family where one member has ocular melanoma, 2 other members have skin melanoma, we have breast cancer, colon cancer? Is there a test that would work to kind of bring that around?
It's a good question. So the test that we do at UCSF, so it's called the UCSF 500. So it's actually a targeted pan-cancer test that we look at. It's Dr. Boris Bashin who developed it. It looks at 540 different genes. So it looks at genes that are mutated in uveal melanoma and a whole variety of other solid tumors and cancers. And for that test, we do actually get a blood sample as well. And so there's germline testing too in that sense. So far among the patients that we've been seeing and treating, and we've used that test for about 5 years, we've not actually identified anything like that. But theoretically, yes, we would expect those kind of things to be picked up on a test like that. In addition, there are other commercially available tests that can be done on blood samples, on serum, that can look for the kind of cancer syndromes that you're describing. Okay, why don't we do one last question? I think we're being signaled to wrap up here.
My daughter has Down syndrome, and I run with a lot of friends who all have kids with different genetic things. have you seen in the Down syndrome world with any kind of eye cancers because of their extra chromosome?
That is an excellent question. So I take care of children with retinoblastoma. At least in my clinical practice, I haven't seen kids with an increased incidence of that particular eye tumor with Down syndrome or trisomy 21.
Any at all?
What's that?
Any with Down syndrome with eye cancer at all?
Not that I'm aware of, and certainly not for uveal melanoma above and beyond what's already been shown in the general population, but it's an excellent question. Yeah. Once again, thank you all so much for the opportunity to speak today. I'm happy to speak with you afterwards as well. Thank you.